It's actually great that that this talk actually was first, because actually typically sometimes they put me like a third or fourth, and it's difficult to talk about this topic after people have presented clinical data. So I'm going to provide an overview of the toxicological aspects and also translational aspects of drug-coated balloon technologies. This is my conflict slide. Most of you actually know Paclitaxel has very unique pharmacological properties. It's a highly hydrophobic drug. Has a biphasic decline in plasma when it's actually given under an intravenous form. And approximately 90 to 98% is bound to plasma proteins. It's got an extensive extravascular distribution and tissue binding. It's actually very special because it really binds to a lot of proteins. And 12% of the dose in urine is unchanged and has extensive hepatic clearance. You guys actually very know the mechanism of action, and this is a drug that is actually considered cytotoxic. This is actually the typical intravenous pharmacokinetic curve, and actually has a bimodal or biphasic actually manner. For the first 12 hours, which is more or less actually the half-life of Paclitaxel, there is a systemic compartmental distribution, so essentially goes into the plasma to different compartments. And after that, the drug actually goes out from the systemic compartment again, and then actually gets excreted. In general terms, actually, the entire half-life is around 50 hours, but the first actually half of the first order kinetics is approximately 12 hours. So in 12 hours, pretty much the drug on a single bolus, 50% of the drug is encountered in plasma. A variety of organ systems can be impacted, producing a range of toxicities. If you actually give Paclitaxel intravenously and you essentially expect to see a side effect, the most common is bone marrow toxicity, primary leukopenia, approximately happening in 11% of the patients, and is actually dose dependent. You see a wide actually list of potential side effects, but if you actually see toxicity related to the drug, the first thing that you should see is bone marrow related toxicity. This is actually a figure that we tried to put together to compare intravenous Paclitaxel infusion with drug-coated balloons. And you actually see that concentration Cmax, which is essentially the peak of Paclitaxel that you would find in blood, is actually below even the detection limits of what you would actually consider therapeutic for the intravenous formulation. You remember actually these curves here, which actually is the typical pharmacokinetic profile, and you actually see here the Cmax for DCBs is pretty much actually very low compared to the infusion formulation. And actually it's difficult to compare head to head, but you actually see the Cmax of drug-coated balloons is really several orders of magnitude, whatever you want to call it, in terms of numbers, but several orders of magnitude compared to an intravenous infusion of Paclitaxel. But balloons are actually different, and the mechanism of action is different. Paclitaxel is not really soluble when it's put on the surface of the balloon. And you actually, as part of the mechanism of action that we have described, the fragmentation of the coating, and particulate containing actually solid phase Paclitaxel is essentially sent to the systemic formulation. So the pharmacodynamics of drug-coated balloons are unique and depend on the concentration and solubility of the Paclitaxel particle, which is different to what actually I just really showed you. After drug delivery happens with balloon inflation, some of the drug remains in the artery, and this is what actually I call an arterial compartment. Then there is an early systemic distribution, and actually other compartments essentially are created in the distal muscle. Some Paclitaxel gets captured, some actually escapes and goes to the systemic compartment, and then there is a late systemic clearance. So as you can actually see, this is not actually linear pharmacokinetics. Particle solubility has a lot to do with tissue uptake and distribution. We have shown this picture many, many times. And when this particle essentially gets adhered to the vessel wall, is responsible for transfer of the drug and actually tissue residency over time. So the particle solubility and type of particle is extremely important, not only at the vessel side of things, but also systemically. We actually now know, we don't have a lot of data, but this is as much as we have right now, that the particles produced for most of the balloons in use in the US actually have a very similar solubility profile. And drug dissolution rates being similar, I think the only difference would be what actually we call input drug dose. If you have more concentration, if you have more drug, you can produce more particles, and therefore, actually, the biological effect may last actually longer. So what do we know about these compartments? This is all data from the Codavance program. This is the early systemic distribution in patients undergoing DCB application. And actually, you see that after 8 hours, pretty much paclitaxel is not detectable in plasma in actually these patients. What about the muscle? We also know, and we have published, that paclitaxel goes into the distal muscle, actually stays there. And according to the type of coating, actually some balloons may end up with more particles than others. But also we have, based on clinical data, there is not an increased amputation rate, at least on the SFA territory, related to the use of drug-coated balloons. And in the experimental model, the presence of paclitaxel in tissue does not really seem to actually delay wound healing. What about the systemic compartment once these particles go everywhere and stay there? If you actually look at all data, and this is being reproduced by others, you actually see that after approximately 6 to 9 months, the tissue levels of paclitaxel, even in the artery, but also in the muscle, liver, or kidney, are actually pretty much below the curve of quantification for that actually determine biological activity. This is actually my last slide before the conclusion, is why I think that Cassano's description of paclitaxel dose effect is way oversimplistic, and we should stop talking about dose effect. We cannot really talk about differences in dosages, just talking about paclitaxel concentration and balloon length, which are actually constant based on manufacturer and actually use or indication. But I put at least 10 variables that can really change the pharmacokinetics and pharmacodynamics of paclitaxel-coated balloons, and this all depends on actually multiple biological, clinical, and technical features. So to be honest, this is actually too complex to just simply reduce to a total input dose, and 2 is not better than 3, and 3 is not actually worse than 2. So this is a conversation we really need to have in the future. So in conclusion, no question, paclitaxel is a cytotoxic drug and induces a constellation of systemic toxicities that are dose and time dependent. The pharmacokinetics are unique, nonlinear, and dependent on solubility profile of each coating. At the highest input dose, the use of DCB results in a lower systemic exposure and transient multi-organ distribution and concentration. And systemic paclitaxel tissue concentrations following DCB use remain below the therapeutic threshold and unlikely exert a sustained biological effect over time. So a lot of people actually ask about my opinion, so I wanted to summarize this in on one slide. Is there a mortality signal? Apparently, actually, yes. The clinical data supports mechanistic insights. I don't really think that we can say that. The pharmacodynamics are different, absolutely, so we cannot really use the IV formulation to support the safety of drug-coated balloons. Is there actually paclitaxel systemic distribution? The answer is yes. Can paclitaxel remain in tissue for years? Scientifically, it is possible. But are the tissue levels actually higher than the therapeutic threshold for years? It is unlikely. Can we see a sustainable biological effect for years? It is actually unlikely, in my opinion. Can we establish a causal relationship? At least until now, my answer is no. Thank you very much for your attention.